May I invite Dr.R.N.Seth, who is currently an assistant professor of medicine at the Hahnemann Medical Center in Drexel University, Pennsylvania, United States of America. This morning, Dr. Seth joins us to speak on high stakes and high uncertainties of thick hearts.
Good morning, chairpersons, my colleague. Since I was late a few minutes, I think I'll condense my slide into this presentation only. And the first slide here indicates the topic as well as the summary slide. I must thank the organizers of this conference who have done an excellent job, not only of a good conference but also of a good weather, and I consider it was through spirituality. For the next 12 minutes, I am with you also. Please focus on all powerful and thick hearts are prone to fall. I'm discussing the hypertrophic cardiomyopathy, and the basic definition of hypertrophic cardiomyopathy must entail the following. It should be unexplained LVH in light of no cardiac and no systemic disease, essentially important, with electrical instability leading to sudden cardiac death, even in asymptomatic patients. So patients may be symptomatic without symptoms, and the symptoms are very variable. It is a condition which is autosomal dominant inheritance with variable penetrance. And it's a gene abnormality. 19 genes have been so far detected with over 435 mutations. This condition of HCM was described by the British pathologist in 1959. It's a variable clinical presentations. A, no symptoms. B, it may be symptoms of congestive heart failure, syncope, angina, dyspnea, or sudden cardiac death, or atrial fibrillation and stroke. Variable echo findings, they have been discussed, and also I'll highlight a few things. But basically it is a SAM and a ASH, systolic anti-motion, asymmetrical septal hypertrophy, and obstruction, outlet obstruction, which may be dynamic. Various treatment modalities, medical, essentially three, beta blockers, calcium channel blockers with negative inotropes, and disopyramide. These alcohol ablation of the septum or myomectomy. And it's a gene abnormality, so gene testing is also important. Since this topic has been partially covered by previous speakers, I have modified all my slides in order to tailor to your needs this morning. 3 important points to remember here. Most common genetic cardiovascular disease, most common cause of sudden cardiac death in young, and sudden cardiac death may be the first symptom. In fact, this year in February, Harvard has described a case report which was presented at the ACC, in which a 25-year-old white male was standing at the train station and he collapsed, and he was found to have this HCM. So in other words, normally it happens in young athletes with vigorous activity, but it can also happen with mild activity or hardly any activity. And as you see, the young athletes 36% of the times die from this condition as opposed to any other conditions that are listed here. 19 genes, I have already said. First gene abnormality described in 1990, more than 435 mutations, and diagnosis and manifestations are the result of additive and synergistic effect of risk factors. The phenotypic expression is basically, I mentioned already, hypertrophy, obstruction, contractility, and onset at any time, 6 years of age or 66 years of age. Differential diagnosis of hypertrophic cardiomyopathy, because as I said, it should be non-systemic disease, non-cardiac disease, and unexplained. So the differential diagnoses are listed here. I would not go into detail because of the paucity of time. So please focus on the disease that I mentioned. Just mention a Fabry's disease, glycogen storage disease, Friedreich's ataxia, myocardial myopathy, cardiac amyloidosis, septal tumors, etc. Also, differential diagnosis of dynamic outflow tract obstruction. Dynamic outflow obstruction is one of the features of this condition due to septal hypertrophy or SAM or both. It happens in elderly patients with hypertension and many other conditions that are listed in the differential diagnosis here, and you may kindly read them. The diagnostic tests, I'm going to mention diagnostic tests, that's why I left it, of the patients or the doctor who's treating. The first diagnostic test is of the doctors, a good history. Second is the good history and good physical examination. Third is a very good history. Physical examination is very essential to carrying out any further testing on these patients. So if the history has not been properly taken, we'll be doing these tests on 7 billion people or so. So good history, good physical examination, and a diagnosis established clinically, and then proceed with the testing. If there's a history of syncope or any other symptoms or signs suggestives of this condition, HCM, then a family history is of paramount importance. First degree, second degree, third degree, fourth generation relatives, you can go as far as you can possibly get into from the patient. The basic EKG changes that we note, it may be normal electrocardiogram, it may be Q wave abnormality mimicking various types of myocardial infarctions with Q wave formation, inferior wall, anterior wall, lateral wall. The third is the left bundle branch block. Fourth is interventricular conduction delay. And the commonest is left ventricular hypertrophy with repolarization abnormality. Echocardiograms, I would not dwell into that, but you all know M mode and the 2D and 3D STE are all important in arriving at a diagnosis, and TDI is essential in this condition. Holter monitor, if there is a history of arrhythmia or suspect of arrhythmia, MRI and gadolinium. LGE is a part of the MRI, late gadolinium enhancement. And I'll focus on that for a few moments later on. Stress test, if there is a suspicion of syncope due to catecholamines. Molecular genetic evaluation is extremely important, and other modalities. The major criteria of echocardiogram and the EKG are listed here. The minor criteria and the recommendations by various societies of multimodality imaging have been recommended in 2011. Mortality in hypertrophic cardiomyopathy, echo can predict it, very important, no time to go into that at this time. Tissue Doppler imaging, very important, no time to go into that at this time. The Myocardial Mechanics in hypertrophic cardiomyopathy is important. Decreased longitudinal strain and increased circumferential strain. Apically displaced twist. Mid-septum goes with the base in hypertrophic cardiomyopathy, and a stiff left ventricle. 3D speckle tracking has been paid attention of late because in preclinical diagnosis, the emphasis is on preclinical diagnosis. It is helpful according to one paper published about 2 years ago. SAM, B mode. The electrocardiogram that I put here looks like normal to all of you, and it would probably when we are reading 100 electrocardiograms in 1 hour. But focus on lead 2, 3, and AVF, and V4, V5, and 6. And this electrocardiogram I have put in for a specific purpose, because this electrocardiogram is quite significant in detecting a preclinical hypertrophic cardiomyopathy. If you see, there is a Q wave in 2, 3, and AVF, and V4, V5, V6. And according to one paper, which was a short paper of only 74 patients, described that if the Q wave is 0.04 seconds in duration and 1 and 5 millimeter in depth, then it is probably suggestive that you should be taking a history not only from the patient of pre-syncope, syncope, or shortness of breath, or symptoms of dynamic outflow obstruction, but also of the family. And you note this in this case, 30% of these cases turn out to be HCM. And this is sudden cardiac death, BFib. LGE. If the LGE shows the enhancement is more than 15% or 20%, then the survival rate goes down significantly. As is shown in this, if its LG is less than 10%, the survival is much better. So LG is a very important diagnostic modality for this condition. Genotype, phenotype expressions. Some genes have a high risk mutation identified. Troponins have decreased penetrance but higher incidence of sudden death. So you can see that in a limited genes, 19 limited mutations, 435 so far, some of them have a predilection for the certain cardiac death or obstruction, congestive heart failure. The clinical history will describe that the patient may present with no symptoms or the symptoms of congestive heart failure, atrial fibrillation, and the cerebral embolism. Now, if the patient's congestive heart failure is advanced, if the patient, let's take the first condition where the patient has sudden cardiac death and has been asymptomatic as the first, these patients should undergo the ICD. If the patient has congestive heart failure, treat congestive heart failure. It's much advanced, you may even consider heart transplant, and of course the treatment of AFib and CVA. Challenges in molecular testing are many. As you see that the mutations may be multiple rather than just one, 3 to 5, sometimes noted in 5 to 10% of cases. And these mutations may produce symptoms or may not produce any symptoms, and may or may not give you the direction as to what the fate of that patient is going to be. So there are challenges in molecular testing relate to genotype, to prognosis. We cannot say that, as I mentioned already. An echocardiogram will remain the sheet anchor and the cornerstone of the treatment of the diagnostic tests of this condition. And clinical history is, of course, a paramount importance. Therefore, in summary, I shall say to you that it is a condition which is worst for the afflicted sportsmen, athletes who are in the prime of their life. Multiple episodes of sudden cardiac death have been noted in non-athletes as well, and they should be diagnosed not only in that patient, but if a suspicion is there, then a strong family history may sometimes come forth only if you ask and dwell into it, because the patients or the patient's family may often forget to reveal that to you. And then you, of course, proceed with the echocardiogram, electrocardiogram, and the LGE and other modalities as required by you at that time. Thank you very much.
Thank you, Dr.